Hello, I'm Hunter Schultz for Winning Healthcare Food Fights. My guest this week is the founder and CEO of the Humanitarian Physicians Empowerment Community, HPEC. It's dedicated to restoring physician autonomy to the practice of medicine. She's a board-certified emergency physician, and it's because of almost 10 years of being one, she recognized a major problem. In 3 words, uncompensated administrative burdens. They're a leading cause of administrative waste and physician burnout. Tired of the status quo, she did something about it using blockchain technology. We'll explore the issues and profound benefits to physicians and patients, starting right now. Welcome to the show, Dr. Leah Houston.
Thank you so much for having me, Hunter.
My pleasure. 10 years as an ER doc, and not just in New York City. You were all over the country.
Across the United States, Miami, San Francisco.
Okay. So you've seen almost everything and then some as an ER doc. And I love asking physicians, especially in specialties, what's the most memorable thing about your time as an ER physician? What are you most proud of?
Well, I'm proud that I really did go above and beyond to get my patients the best care. And even though I was working in systems that really did not make it easy for me as a doctor, oftentimes extremely understaffed, not enough resources to do the right thing for people, I am proud that I did take that extra time to make that extra phone call, to make sure the social worker saw that patient, to make that phone call the next day to somebody that I did discharge to make sure that they did get the follow-up. And I'm lucky that I survived also just as a doc, not having had a lawsuit. I mean, knock on wood, it was a pretty dangerous situation where I could have easily made errors because I just was seeing too many people in such a short period of time. So I'm very grateful for that.
Sure. I can, the cultural influence of in medicine for most people now is hospitals, ER, Grey's Anatomy, House, the list goes on and on and on. Whereas my generation and older, I'm 60, my generation and older, it was Marcus Welby. Yes, there was General Hospital, the soap opera, but Marcus Welby, MD, was a top-rated show, and it was just a family doc. When I say just a family doc, I don't mean it that way. I mean, it was just one doctor, well, there's 2, his protege, Stephen Kiley, if memory serves, played by Stephen Brolin, Josh Brolin's dad. Well, anyway, he had time for the patient. And so what I just heard you say about making a phone call to make sure they got the follow-up care, that's a big hole. I mean, that must have been frustrating for you, knowing after they leave, where's primary care in all this?
Right.
It certainly was not Marcus Welby. So, leading into segment 1, I read on your Twitter account, your profile, which we follow each other, which is where I've seen your posts and enjoy, the content you share. A hospital stole your identity. I'm thinking foreign countries do that kind of thing, but a hospital? So I may not be the sharpest pencil in the bunch, but what you're doing now has got to be related to with HPEC. It's got to be related. It's got to be the trigger event there somewhere that said, "Oh no, I'm not taking this anymore. I'm going to do something about it." So how close am I? What's the backstory to the hospital? And
Well, this is actually an extremely common problem that people aren't aware of, especially when it comes to emergency medicine care and primary care, and a lot of other specialties that are very collaborative with other, other providers that are around. So as a doctor, whenever you work for someone else, and even when you work for yourself, but when you work for somebody else, you have to give them access to your professional identity. And then they use that professional identity in order to bill for your services on your behalf. So what's included in that? My medical license number, my NPI number, which is my National Practitioner information number or something like that. My PTAN number, which is my ability to bill for Medicare and Medicaid for the Department of Health and Human Services. My DEA number that allows me to prescribe narcotics and controlled substances. So in order for them to bill for any of those services, they need to have access to those numbers. And so in order to be employed, in order to have a job as a doctor, you have to give away all the rights to those numbers, and they bill under your name. And you go about your work and you assume that, they're billing and then they're paying you a portion of it and they're taking the rest and they're doing their administrative thing and all is good. But what was happening with me, and what is happening likely to many other physicians, is that they had me as a supervisor role to a non-physician provider who was caring for patients I didn't even know were being cared for under my license or under my name, even while I was working there. And then when I left, they continued to bill under my name. So my name and likeness has been attached to I don't know how many charts of patients that I never even knew existed.
This sounds like a recipe for malpractice disaster.
Yes, and to be honest with you, there's varying levels of this. For me, I think it was the most extreme, where I didn't even know it was happening. But for others, I think it's a more subtle thing. Oh, just sign these charts that you're supervising. Some docs, okay, I'm just going to do as my employer says. Well, they weren't actually supervising those cases. They weren't actually aware. Maybe they read the note, but is that what actually happened? And so I totally agree. It's a recipe for disaster. I do think it's a malpractice situation waiting to happen. I do think it's Medicare, Medicaid, and insurance fraud, because those are services that were not rendered by me, but were billed. And so, yes, this was what occurred that led me to come up with the HPEC solution.
Wow. That must have been just so a violation. I don't want to use the word rape because that's even worse, obviously. But I would feel incredibly violated, I think. I can't imagine that. I'm not a physician. But that's your professional reputation on the line.
Absolutely.
Just, it seems to me that forgive the pun, but Houston, we have a problem.
Absolutely.
Have you heard that one before?
So, never.
Never, no. Granted, now my questions are from a ninth grader's perspective because I don't know what this means as much as Doc would. But from a doctor's perspective, so let's just say the audience right now are physicians. What would you say to them, that audience? And then we'll talk about the patients, because obviously this is going to impact patient care. I know that much. I have a little bit of knowledge. So what would you say to physicians right now? Because physicians need, and I'm not talking even COVID-19, although that's a battering ram. What do you say to physicians? What would you tell them?
About HPEC?
Yeah, about the solution.
Okay. We have a right to understand and control our professional brand and our practice. We have a right to know who is billing under our name, what they're billing for, how much revenue they're generating off of us. I coined the hashtag RVU factory. We all often work under the RVU, incentive program in large health systems, especially where they're tracking us, tracking our behavior, and attaching a monetary value to every little thing that we do. And, we become RVU factory workers, where we're just pumping out as many RVUs as possible. And it's unacceptable to me, and it should be unacceptable to you too. We have a tremendous opportunity right now to pick up this technology and to own and control our professional selves, to own our right to work, to be able to monitor what's being billed under our name, and to be able to control it and prevent not only fraudulent use, but also to protect that information. Because what they're doing right now is Shoshana Zuboff coined the term surveillance capitalism. What they're doing is they are surveilling our behavior as doctors, and they are capitalizing on that behavior. Dr. Smith only ordered 17 EKGs last week, and Dr. Simpson ordered 87 EKGs last week. Dr. Simpson's revenue was higher. What can we do to get Dr. Smith to order more EKGs? Oh, Dr. Smith, you need to order more EKGs or else you're not getting your bonus. They're tracking us. And instead of that information being private and hours only, with us being able to do our own internal analysis and making adjustments based on what's best for our patients, we have these systems that are pressuring us to really do unnecessary medicine, duplication of services, inappropriate referrals, because they're squeezing us to be fast and they're squeezing us to produce and churn out. And that's what this is about. This is about taking back that right to that privacy for physicians, and then ultimately for patients as well.
This is sounding, I've made this analogy before, because when I was in my teen years, it's 70s, my teen years, Detroit was a mess because of the oil crunch, and they had a monopoly for so long, and then the Japanese came in and said, hello, Ohio.
Mm-hmm.
And they came in with quality, they came in with cars that people wanted, but Detroit's mentality was managing by the numbers. So you had this assembly line that the managers would say, no, we need to crank out 100 cars every hour. And the workers were saying, yeah, but the parts aren't fitting. Doesn't matter, just go. The people will buy them. Doesn't matter. All of a sudden, the assembly line workers knew we have an issue here. And so, part of the angst of the 70s was each side was blaming the other. And it took W. Edwards Deming and Dr. Duran and a few others to say, hold the phone. If management creates the system, they're responsible for it, number one. But number two, managing by the numbers is wrong. Yes, data is important, but you have to go deeper. What's driving the numbers? And so even though Deming and the like, they were all quality, they did things with data, but what are you measuring? And what's really important here?
Bingo. What's important? And
Yes. It applies to medicine from a primary care role or anything. What's important for a doctor to know about me? And guess what? The number of tests have grown over the last, 20, 30 years to thousands. Well, what's important to me is different from you.
Right.
We're in personalized medicine territory here. So that opens up a whole can of worms for big systems, whether it's government, insurance, anyway. So what are the roadblocks here? What needs to change?
In order for this to be adopted?
Yes.
Well, I think first, both physicians and patients need to acknowledge that many of us have Stockholm syndrome. Many of us believe that we have to just deal with it, that we have no choice, that we have to continue to just, they're going to increase the bar for us as physicians, and we have to keep meeting it, and they're going to keep increasing it, and we're going to have to keep meeting it, and da 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 da. We need to stop and realize that that's absolutely not the way it needs to be. We need to realize our You know, we are the ones with the pen. We're the ones with the power of the pen, or the power of the keystroke now, I guess. Without the stroke of a doctor's pen or keys, nothing happens. You don't get a prescription, you don't get surgery, you don't get admitted to the hospital, you don't get anything. And
Sounds like
so
you're
we
not doing the
have,
signing.
huh?
It sounds like you're not doing the signing, though, on a lot of this stuff.
Well, I wasn't in that particular
Yeah.
situation, but that was fraud, you know? And so I think what I'm saying is we need to acknowledge that our professional license, our identity, our credentials as doctors is very valuable. Without it, you can't do any of these things. And so we need to take back ownership and control over that so that we can restore that privacy and trust to the doctor-patient relationship that was once there, you know, not too long ago.
Yeah. I mean, what you're doing is important for docs, so much so. And you mentioned patience, and I want to segue into patience because of time, and you and I could probably talk for 5 hours. I know that. But in the interest of time, what should patients know, and why should they care? You've kind of answered a little bit of the what should they know, but maybe from a what would you say to the patients, and why should they care about this?
Um, your doctor, a person who went through the rigorous coursework of medical school and residency in order to understand the complexity of the human condition and the human body and the science behind it, to be able to help guide you through whatever health situation you're going through. Every single one of them took a Hippocratic oath to put you first, to do no harm. And in my opinion, that oath now extends to your digital privacy as a patient. And just like we are being surveilled as physicians, and they are monitoring our behavior and our prescribing patterns and our referral patterns, they're also observing and tracking the behavior of patients. How much did, you know, this patient spend last year on their health care? People who are being monitored on some of these devices, they're selling that data about you. Yes, they're anonymizing it or pseudo-anonymizing it, but that's still data that you're producing for these companies to essentially extrapolate value from. So you have a right to privacy. You have a right to ask for a physician, and you have a right to protect the privacy of your data. And that is what this movement is about. You know, this isn't just a company I'm trying to build to, you know, help doctors. This is, we're trying to create a paradigm shift in how medicine, how the ecosystem exists. We're putting doctors and patients closer together and cutting out those middlemen who are, you know, surveilling all of this data between doctor and patient, and it's none of their business, really.
Yeah. Yeah. I I had an idea last night, and I had a feeling that it'll dovetail nicely into something that I've said before in the show, and that is it will take a crowd to change the crowd.
Bingo.
And the crowd is Americans. But you need a crowd in order to get the message out. And that crowd needs to be tightly focused, and that's what the DPC Sherpas are about. And if anyone knows of a DPC doc that would like to be, or a doc that would like to be DPC in Okeechobee, Florida, I've got a Sherpa there that is looking for a DPC doc for that because they don't have it, and they know they want it. Getting them all on the same page, and then educating them, and then having them spread the word. And I thought part of this is, would it help to have patients saying something? And I thought, wait a minute. What if I brought you in to see my doctor, Javier, Dr. Javier, here, who's direct primary care? And I had you sitting beside me, and at some point, I say to Javier, you ought to give a listen to Dr. Houston here. What would you say to Javier in a 20, 30 seconds so that I, as the patient, am watching Javier's reaction? Sort of like when I say, if you don't get primary care right, doesn't matter what you do with coverage. It it doesn't work
Bingo.
because care is the critical issue. You don't get care right, forget it. You're screwed. Any system, globally. So if you can't think of it now, that's fine. But I want to drop this into your head. If you've got someone like if I
I
have
have a
my cell
perfect.
phone,
Yep.
if you had a whole bunch of people going into their doctor and could press a button and have you pop up in a little clip, and you're talking to the doctor, not in a negative way, but hey doc, da 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 da,
Well, this
and
is
the
what I do
patient,
every day, you know.
yeah,
But there's something very interesting though. First, you said if I was going to your doctor, who happens to be a direct primary care doctor, and then you said if anybody was going to their doctor. Two very different things,
true,
you
true,
know.
true.
Because
Pretend
on
it's
one
not direct
hand,
primary care. Pretend it's me just going to a doctor, my primary care provider or doctor. What 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 might you say so that the patient goes, whoa, we have a problem here. I better start demanding change because you need the crowd, I think, to demand the change
right?
on behalf of the doctors. And that isn't going to happen until people are beating down the doors of Congress and state legislatures and saying, hey, we don't want this anymore. And that's the only way that politicians are going to pay attention. And that's not happening because no one's on the same page. Hence, a crowd needs to get the crowd going in the right direction. So, just an idea that hit me last night. What could Dr. Houston say to my doctor that would enlighten both me as the patient, but start doc, have a listen. What do you think? You can always come back if you want to send me it. You think about it. If you don't
No,
have
I
it,
don't need to think about it. This is all I do all day, every day,
okay.
is talk to doctors about this. I mean, this is, the issue is it's often a conversation because every doctor is different. A radiologist is going to understand and you know, receive a different message than a DPC private practice doc. But
Right.
you know, so it's harder to send that broad message. But to the general population of physicians, we all agree that this healthcare system is completely broken, and we all agree that we are being abused by the system. Whether you feel that abuse more through the decreased reimbursements of insurance or the increased prior authorizations, or whether you feel that squeeze from your employer pressuring you to see more people, or whether you feel that squeeze from having to spend an increasing amount of time on uncompensated administrative tasks like EHR, we are all feeling the squeeze, no matter what specialty we're in. And if you kind of take it back, everybody's feeling the squeeze from the fact that they're trying to control our behavior. We are the ones that provide the services to patients. The patients are demanding our services. There is a shortage of physicians. And so the system is trying to find ways to control, track, and monitor our behavior so that they can squeeze as much out of us as possible. And this is a solution that will put us back into control, that will allow us to once again uphold the Hippocratic Oath. Because in my opinion, many of us are not able to uphold the oath in this current system. We are not able to because we are in constant conflict with, the medical industrial complex and that oath that we took.
Yeah.
So I don't know if that was 30 seconds, but that's,
Whatever it takes. But it's not I mean, as long as it's under 2 minutes, I think we're good. The point here is that I think it'll be great because I'll spotlight that and enable people to just pull up that video and say, Doc, what do you think of this?
I would love that. I would share that clip, of
And
course.
watch the doc. I mean, I can see the doctors. I know enough that I know doctors would be going, yeah.
I'd like to say something specifically to direct primary care doctors also, if
Well,
that's okay. Can
you'd
we
say,
do clip?
go ahead, go ahead.
Okay. As direct primary care doctors, we all feel like, oh, yay, we did it. We unplugged from this horrible system and now we can take care of our patients. Wonderful. I'm very connected to a lot of DPC docs. What you guys are doing is not easy, but you are actually upholding the Hippocratic Oath by doing the right thing for your patients and untethering yourselves from these surveillance models, which is really what it is. The problem is someday your patient is going to need a neurosurgeon or a cardiologist or a urologist or a dermatologist. And unless we acknowledge that we need to find a system that empowers all specialties, and we need to ensure that all of our colleagues have access to provide the care to the patients that they need, then we are in some ways doing a slight disservice. So, even though you're no longer tied to EHRs or insurance and all these things that I'm talking about, unless your patients will never need a specialist and you're 100% certain of this, we do need to start thinking about this system where we are going to give this to each other as a gift for our profession to restore autonomy and agency for all physicians so that we can properly care for our patients regardless of what comes across their lifespan.
Yeah, good one. I'll create one for that. I think that's
Okay.
good. But I think it's important. I really think it's important for the public as they become more aware that, and there are other things, there are other little clips that I want to do along the same lines of proving the point. For instance, there are a lot of well-intentioned people out there. Medicare for all. I I understand the appeal for a lot of people because they're so frustrated, and they're like giving up. They don't realize what they're giving up. There's a lot of ignorance. If they knew how much surveillance was going on just with Medicare and Medicaid right now, for instance, in the Federal Register, there's a whole section on surveillance of electronic health records. And within that is a really funny line, and that is the government has access to those records without patient authorization. 3 little magic words. And then I actually looked, I'll put it up in the screen. I'll put the 2 things up in the screen in the show. First one is this without patient authorization. The second one is I started seeing surveillance. When I read this, I started seeing the word surveillance, and I'm thinking, wow, is this a typo? I mean, what surveillance? And this wasn't that long ago, post Edward Snowden, when people were having kittens over emails and phone calls. Oh my God. Well, it just so happens that the NSA would have to go to a court in order to actually listen to the phone call or read the email. And I got that from the top, a friend of mine who worked there. And he told me exactly what was needed. He goes, I wish people understood that. It's not like we can just open them up and go, oh, look at that, for an American citizen.
Yeah.
So they had to go to the FISA court in order to open the email or listen to the phone call. Well, I did a control F on this document to find out, is surveillance, is that just 1 or 224 times within that little document? This is a mindset.
Yeah.
And this is all about the ability to do audits on the doctor. Audit quality measures for the EHR to make sure it meets standards set by the government. So they send in a registered nurse who has access to all the data.
Mm-hmm.
And essentially, they're going to look at does the reason for the visit match the diagnosis and the treatment plan. Does it add up? That's one thing. Because frankly, if you're spending government money, taxpayer money, there's an audit trail, and we would expect that.
Yep.
Well, they do have that audit trail right now, but it's incredibly invasive, and most people haven't a clue of without patient authorization. And that came in December of 2016.
Well, the authorization is implied. The day that you choose to use your government-sponsored health care, your Medicare or your Medicaid, you are consenting to the sharing and the surveillance. If you want to pay cash, then you don't have to consent to any of that stuff.
Right.
It's your choice.
The problem is most people don't have that. They don't have a choice, number one, which is the beauty of direct primary care, because a lot of the stuff that happens in someone's lifetime is going to be handled at the primary care level. And government having access to that data, going into one big government database, it's the world's most hunted database. And they weren't too good with the OPM data, which is security clearance data. 20 plus million people with security clearances. Somebody broke in and stole the data. And that's similar to medical information, because they're asking very tough questions. And those, the higher up the security clearance chain, the more fun the questions are. So, and part of what I talked to, when I talked to Twyla Braze about it, was the Fourth Amendment. They go right around the Fourth Amendment with third-party doctrine. The funny thing,
go ahead.
Go ahead. You're the expert. I'm just a guy.
I'm definitely not an expert on this. I have not, read this document that you're talking about, but I've read similar documents. And, according to Fourth Amendment property rights, if you create it, you own it. And so as a physician, if I'm creating the information from the encounter, the documentation from the encounter, unless I choose to be employed by a system that captures this data and takes it, or use an EHR, third-party EHR system that takes this data, then that's my property. And according to the 21st Century Cures Act, which was recently finalized a month or two ago, that property needs to be easily transferred and accessible to the patient without information blocking. And it needs to be interoperable with other systems. And so, we're kind of at a crossroads right now where we're going to continue to participate in these systems that are surveilling us, or we're going to build new systems where we have more transparency and choice around what they are and are not allowed to know about us. And if they do know, we should be aware. It shouldn't be some passive consent. It needs to be active consent around these things for both physicians and patients, in my opinion.
Yeah. You mentioned something there that I've seen the discussions about who owns the data. When the patient, the third party doctrine is how government gets around Fourth Amendment. There are other things that impact patient privacy as well. Supreme Court decisions and expectation of privacy. But I think maybe you can address this maybe a little bit, that how much of what I tell you as a doctor, how much of that is mine? Or it's a unique thing. If I'm telling you about something that happened to me, I did something dumb, and I went to Rio on a spring break, and there were 9 people on a beach. One person was watching. It was a little weird. I've never been to Rio, but if I do something that would be embarrassing, that data is mine. How much of it is mine, and how much of it is yours as the doctor? This seems to be maybe I'm missing something. So maybe you can help clarify. How does that work?
Well, legally, in all states except for New Hampshire, the electronic medical record, the record of care, belongs to the physician. The reason is that we are required by law to keep these records for a certain number of years, because if something happens, we need to be able to share it with the patient or with the next care, the next person that's taking care of them. And we also, from a medical legal standpoint, need to have these records so that we can prove what actually happened, and defend ourselves in a court of law if and when a malpractice claim comes up.
Sure.
Also for billing audits, if we are taking insurance, we have to have records in order to address the clawback problem and things like of that nature, and we need to keep those records for the long term. So from a legal standpoint, the physician owns the record. Now, I'm of the camp that even though we own the record, I think patients should have close to immediate access to whatever it is we're documenting about them. And I also think that patients should have a right to comment and potentially correct errors in these records. And right now, on paper, you can write to your hospital and say, hey, you said I have schizophrenia and I don't. But will they listen? Every hospital is different with how they manage and handle those things. So in my opinion, when I say autonomy for physicians, part of the reason I think it's very important for your individual doctor to actually have autonomy and for you to have a relationship with that person is so when these kinds of things come up, you have a one-person situation that, you can have that conversation rather than having to deal with some third-party behemoth that may or may not pay attention to your claim. And there is, in the current EHR systems, there's a lot of dirty, incorrect data. And it's not always, the fault of the doc. Somebody along the way could have, in triage, or, a medical student or a resident, or, an NP who was, taking care of the case before you, puts that the patient does or does not have diabetes. And then next thing you know, you have diabetes on your chart. You don't have diabetes. Or, you have duplication of things, incorrect dates, incorrect sides, right hand, left hand. In my opinion, as a patient, you should have the right to comment or correct directly and immediately when you notice these corrections, and you should have access to all of these records immediately. And there's some docs out there who disagree with me, but that is, I feel very strongly about that. I think it's their right to know what's being documented about them.
It's part of the personalization of medicine.
Yes.
I mean, there's so much more coming in. I mean, 20 years ago is when Genome, it was 20 years ago, a little over 20 years ago now, that the announcement was made of the first mapping of the human genome. It was July 26th, I think, of 2000 when President Clinton announced it. And I'm sure as a physician, or you were probably in diapers back then, you probably
I actually was in college, and I have my degree in molecular biology and biochemistry, so it was a very exciting time for me.
So that must have, I can imagine, I didn't pay too much attention to, oh, that's cool. I wonder if that's going to tell me if I'm going to, when I'm going to die, which was not the case. But I'm sure for a lot of physicians, they went, ooh, this is sort of like the Apollo moon landing of medicine. It's a game changer, because now, I mean, when I would walk into your exam room, before that, you're just looking at me as a male and running the male flow chart. Female walks in, you're running the female flow chart. Now you're running Hunter's flow chart. Wait a minute, I have 3,000 patients. How's this going to work? Now, they didn't have to worry about that right away because it was $2 billion and took 10 years at that time. But now we're a couple $100 in one day, less than a day. Hello. we have a problem here. And that is, doctors don't have the time.
Well, I don't think that that's a problem. I think that it's not, I think there's going to be, especially if we take control of the situation and have some ownership over the tools that are being used and deployed. I think we as physicians, this might make our lives easier in some ways if these tests end up becoming what I hope that they become, you know, to understand the epigenetic factors around why this 45-year-old gentleman with hyperlipidemia who's been on this drug for 10 years and this similar guy, one gets a heart attack, one doesn't, really understanding from an epigenetic standpoint what is causing this. Oh, wow, this gene is turned on by casein, which is a protein in milk. You should stop drinking milk. Boom. You know,
Yeah,
decrease, heart disease reduction,
that's
harm.
the benefit. I mean,
Exactly.
huge benefits. It's just that it takes
Exactly.
time for for a doctor to sort through all the data and the
I
testing.
think that that's a purposeful problem, and that has to do more with our current system and our current dirty EHR and less to
Yeah.
do with progress. I think progress will actually fix that, where we will be able to quickly say, oh, well, these are the 7 genetic tests that you should be doing for your current problems and based on your family history. And we're going to send those out. In a week, we'll get them back and we're going to have a better plan for you.
Yeah.
Um, that day is coming soon, in my opinion. And it's not going to be, it's going to be great. And
Yes. I'm all for it. I just want you mentioned something related to it, and that is having someone who's the focal point for care. Your primary care doctor is your focal point, and that's the connection that with what you're doing is that that doctor has more autonomy and more control and be able to correct things, help correct things. That's a really important point that I learned today that I did not know. So even better. Is there anything that you would like to say that maybe I have a question that I have not asked or something that I didn't bring up that you really want to say, hey, pay attention?
no, I mean, I really appreciate this time, and you've asked some really great questions. And,
Thank you.
I guess I would just want to reiterate that you have a right to excellent care. You have a right to privacy whenever you're getting that care. And you have a right to complete autonomy and understanding if you aren't getting that privacy. You need complete transparency at every level. There is no reason that you should break your leg, go to some urgent care place, and not know what the cost is going to be. There is no reason for that.
Yeah.
The system has confused people into thinking that this is just so complicated and we can't figure it out. No, not true. It's the system that has complicated it.
Yeah.
So this is a real opportunity to fix that problem.
Music to my ears. There's majesty and simplicity. I think that's what confuses people. They just assume. And I know there are people who are banking on that to continue. Because what happens if people really wake up and go, wait a minute, there's an easier way with better care? And oh, by the way, it costs a whole lot less? That education. Thanks so much for joining me, Dr. Leah Houston. It's been a pleasure. And
Likewise.
Godspeed in what you're doing.
Thank you.
You really, you're really doing good work. Keep it up.
Appreciate it. Thank you.
For winning
And if you
healthcare,
want, oh,
go ahead.
no,
Go
I
ahead.
was just going to say, I forgot to mention that, we are in the middle of a crowdfunding campaign, meaning anybody can become an investor in this project up until the election. We have this open. So for as little as $250, you can throw your hat in the ring towards the future with privacy, autonomy, and freedom for healthcare in the future. So think
Okay.
about it.
So is there a link to that? I'm going to put links
Right
in the
on,
description.
right on my website, hpec.io.
Okay. That's going to be it'll be on the screen as well as on the website. So, I mean, in the description. So you're going to have plenty of opportunities. I'm glad you got that in. Because I did not
Yeah,
know.
I didn't even remember. I forgot that we're doing that right now. But it is a very unique opportunity, and this is a chance for us to take back control over the practice of medicine and to have
Hmm.
restore privacy and
Yeah.
trust in the doctor-patient relationship.
Is it it's not just doctors that can do this,
No,
meaning it's not
anybody.
anybody. Okay, it's open to anybody. Okay, good. So we'll spread the
Yeah,
word.
and there's a lot of patients who have actually invested. There's also some healthcare executives that have recently invested because they said, I've been doing this and I know it's wrong. And I see what you're doing and I know it's right. And that's been very encouraging and really exciting to see also.
And I've noticed, I think I saw the page and I noticed world famous Dr. Molly Rutherford's one of the investors.
Oh
She,
yeah, she's fantastic. I love her. She is, pounding the pavement as a DPC doc, really, helping to spread the word and care for her patients in the right way.
yeah, one of the treasures out there. Again, thanks so much. I've so enjoyed this.
Likewise, it's really been a pleasure. Thank you.
For Winning Healthcare Food Fights, I'm Hunter Schultz. Stay healthy, wash your hands a lot, and there you are.